My name is Mercy Juma, and I am very, very proud to say that officially I'm the moderator of Real Talk. Anybody here who's done Real Talk online? Ooh, yes, we have a following. For those who have not heard anything about Real Talk, this is where we have raw, candid, unfiltered, honest conversations. If you have been a panelist the last few days, probably somebody sat down with you and gave you a list of questions and prepped you and told you this is the agenda, these are the objectives, this is what we want to achieve, right? Yeah? Yeah? Yes. I can confidently tell you that the panelists you'll see here today have not done any of that. I have not given them the questions. I have not given them the questions. I have not told them what I am expecting. I have only one ask for them: to be real, to be raw, to be honest. Why? Because if we really want to shift the needle when it comes to maternal newborn health, we need to have those conversations. So we are allowed to disagree, and that's why we're here to do today, disagree. We started with Real Talk 1 online, and we looked at the workforce and asked ourselves, what happens if the gap won't close? We moved to Real Talk 2 and we looked at innovation and we asked ourselves, so what if nobody pays to sustain the innovation? And we moved to 3 where we looked at prioritization and we realized that decisions are not made entirely based on evidence, but they are determined by budget and politics. And all that brings us here to Real Talk 4, which is being recorded and is coming to you live from Nairobi. The other 3 were all virtual. So thank you for staying put. And for Real Talk 4, we are looking at the global health agenda. The system is changing, right? So what is the place of mothers and babies in this changing system? How will they adapt? Do they become central? Or do we assume that the system will carry them along? That's the question we're tackling today for the next about 57 minutes, because I think I've spoken for 2 minutes. For the next 57 minutes, that's what we'll be handling. And this is being brought to you in collaboration with AMREF Health Africa. Thank you so much for being our partners for Real Talk 4. We really appreciate that. Thank you very much. So please allow me to welcome these 3 wonderful humans on stage. Dr. Ann Kihara, President Emeritus of FIGO, who's also, can I call you a friend now? Thank you. Thank you. Who's also a friend. Please, Doc, karibu. You can take this seat next to me. I will sit on that one. And then we have Dr. Caleb Mike Mulongo, a health financing and health system specialist consulting at Tunu Consulting. Karibu Mike. And Boniface Mbuthia. By the time I start calling you Bonnie, no, you are my friend. Whether you like it or not. Boniface Mbuthia, Technical Director, Health Financing at AMREF Health Africa. Normally I would start with a panel, but today I'm not starting with a panel. I tasked Ndrani here with just one thing. Go up the stairs. Wherever you choose to stand, go up. Give the mic to anyone. Give the mic to anyone. Anyone. Yep. She chose you. I didn't choose you. What do you understand by the phrase global health reforms?
The dismantling of the global aid architecture and where we go from here.
The dismantling of the global aid architecture and where we go from here. That is what global health reforms mean for you. Give that mic to any other person. Choose. Hello. Yes. What do you understand by the term global health reforms?
I think for me, global health reforms just maybe like the systems and policies in place that govern our global health agenda.
All right.
Attempting that. Yeah.
Great. Thank you. There's no right or wrong here. One last person. So choose a person. Global health reforms. What does that mean for you?
So to me, global health reforms mean standards that are being set to revise or to reconstitute what is normal to the future, or aligning to the future needs of our financial needs, so to speak.
Ooh. All right. Thank you
Yes,
so much.
Prof.
Okay, go ahead. Did you want to add something?
Yeah, related to the agenda of the future.
Yes.
So aligning the reforms from a financial perspective to speak to the needs of the future. Yeah.
Needs of the future. I love that from the finance perspective. Did anyone talk about maternal and newborn health? No one spoke about maternal and newborn health. And in these global reforms, thank you. No, the mic is already off your hands. The mic is already off your hands. We'll come back to that. All right. I'll come to the three of you now. And please, if you have any questions for our panelists, please get them ready. After about 15, 20 minutes, this will be very open to you. Doc, what does global health reforms mean? And as you answer that, I want you to speak to my 85-year-old aunt in the village.
Global health reforms, for me, I start with the centrality of women and babies and children. Why? Investment in human capital. All of you here are here on account of what? A beautiful woman who decided to have you, to nurture you, bring you to maybe some of you age of maturity. And why am I very emphatic about the centrality of women as the bedrock for development? If you gave me a chance today, Mercy, and said, Anne, be the product, optimally working, trust me, I'd make more money than these guys any day. The financing. And let's be very serious and very real. Mm-hmm. Women, if given an opportunity beyond reproduction, would actually change society. Mm-hmm. And I'll ask a question differently to all of us. Sustainable Development Goal 1, reduction of what? Poverty. Is there a role for women? We have in this country table banking, chamas. Now I'm talking to the Kenyans. Number 2, what are we talking about? You see, they don't even know these things. So I'm having a problem. So the global health reforms must put the centrality of development agenda in totality. And I put it as 5 things. Address your planet, address peace and security, address partnership, address having progeny. Progeny is offspring that can carry on and perpetuate the development agenda. So if you begin to see things in that way and put people at the center, and unfortunately or fortunately, who is given that role? It is women.
Women.
Nowadays, we don't even need the man.
I'll
We're
stop
going
you
for
there.
AI.
I'll stop you there, Doc,
You
because,
know?
listen, I know you can talk about this for the next 3 hours. Please allow me to move into Mike. Mike, Doc has said she can make more money than you given the same
Definitely.
platforms. But before we go there, global health reforms. And Doc, by the way, you didn't speak to my 85-year-old aunt.
Yes.
In the village. So just pause there. Let's see if the gentleman can speak to my 85-year-old aunt. What is global health reforms?
No, thank you very much. For me, just as has been said, it is decisions are made, yes, but then how those decisions translate to the person on the ground, including your 85-year-old aunt, then matters. For instance, if it is about mothers and children, previously, we know for a fact that a lot of our reproductive health services are donor funded. So these decisions then mean that the mother who was getting their family planning commodities from a facility nearby now has to walk a longer distance to get the same services simply because government hasn't bridged that gap in terms of financing the availability of his family planning supplies. The mother who was taking their child to immunization or vaccination closer by now has to move a longer distance or skip their schedules simply because some of those vaccines are no longer readily available, simply because the donors who are funding this have pulled out, or they have made decisions that then affect the availability of these services closer to them. So translating those top level decisions to the lived experiences on the ground, and ensuring that that disconnect is reduced to the greatest level possible.
All right. Thank you. Bonnie, do you agree? Is that what global health reforms mean for you?
So global health reform, and I want to use a very simple definition, would really be how the world makes decisions on health, what policies and laws they follow, and then how those decisions then go down to the grassroots. But I also want to add something there, that when we talk about global health reform now, then we're also talking about it is changing in the sense that before, the world was coordinating health in a certain way. For example, using parallel programs, using donor aid, and so on. And so that is changing to a point where we are now saying, now, while those decisions used to be made up there, those decisions now need to be made down here. But without compromising the value of services that you are entitled for.
How do we not compromise the value? And any of you can come in on this. How do we not compromise a value for mothers and newborns, Doc? Because I think that's the most important thing for me. How do we not compromise that?
I think one way is to first understand what is the real value of a good service to anyone, because that's what really promotes humanity. And many times when we develop policies and we are involved in these high-level discussions, we sometimes assume that we are making the health for those people who live to a place that we can't see. So it's more about remembering that when we make any changes in the health system, I'm making those changes for me and the person who is closest to me. Not the other way. I'm not making the health system for those people. I have to make it for me, because if it works for me, then everyone will get good service.
I would start by thinking of valuing and ownership of health. I think for the longest of time we've had, and for lack of a better word, a colonial outlook to health. I'll say it as it is. A lot of the decisions were made from high-income countries, directed to low-income countries. Within low-income countries, we've had a dependency syndrome, where we've actually begged for resources, begged for personnel, begged for equipment. That's the truth. And now we're saying you need to first and foremost own your health. Let it matter. And this is why I keep going back to the word human capital. Prize your own citizenry. And it starts really with the mother, the newborn. And begin to start putting funds where they're needed. Begin to start looking at self-reliance within the health system facets. Begin to start looking at the quality of services being rendered and accountability. I like that word, accountability. Being accountable for what you're giving your citizenry. That to me is what it points to.
No, thank you very much. Maybe just to pick up on what Prof has just mentioned, I think if we are not to compromise the quality or the compromise what then translates to the person on the ground, then we have to, as government, we must then prioritize the health of mothers and their babies, and by general, just the health of your populations. I think the reality is that governments exist for the welfare of their populace. So then if that then holds, then the priority instrument for the government is not talk, it is a budget. So the question is, in the government budgets, are we seeing the health of mothers and children as a priority? Can you track what has been approved and then you see mothers and their newborn children? That's number one. Then the other bits are just really structural. So there is evidence around what is quality maternal, newborn, and child health. Have we embodied those standards? Do we enforce them? And as a system, do we learn so that then we continuously improve the quality of care? So it's not just about the money, because yes, you can see the money in the budgets, but what are you buying with that money? What results are you getting from the investments that you're getting? So that then the question around value is not just about how much is spent, but also how well is it spent, and what results in terms of mothers and their children and their health outcomes, what are we seeing along that path? Thanks.
You know, you are asking me questions I should be asking you, Mike. Like, are you seeing what the money is buying now? Just pause there. Are you seeing what the money is buying? Are you seeing the budget lines that are specifically for mothers and newborns? Are you seeing the standards set? So you should be answering these questions, not the other way around. You should be answering these questions, not the other way around. So you ask the questions.
So she said
you answer
it's real
them.
talk.
Wait. You answer them. And as you answer that, and Prof. and Bonnie, you'll also ask this, tell me whether you think these reforms are an opportunity for MNH or not. So answer your questions, then answer mine.
No, good one. And where do I start? So are we seeing the health of mothers and their children in our budgets? So if I look at, so there's work we're doing at the moment, and we're trying to look at investments in reproductive health, maternal, newborn, child health. And one of the things that is standing out is that you will not see, it is very ambiguous in our budgets. I'm just looking at now Kenya, for instance. So if you're trying to look at the program-based budgets and you're looking for reproductive and maternal and newborn and child health, so it is very ambiguous. And even where you see it, it's across many sections, which is not necessarily a bad thing, because you're talking about integration ultimately, because you don't want to verticalize or silo things. That's one. But the other reality we notice is that even what has been approved, which is little, doesn't actually get to the facilities or to service delivery for whatever reasons. That's one. When it comes to quality, the reality is that even by virtue of us hosting this meeting in Kenya, it means there is some reputation Kenya has as far as standards is concerned. But having standards and upholding standards is a totally different thing. So the question is, I think the bigger question now is on the enforcement of standards. And I'm happy President Emeritus of FIGO is seated here. So she will talk about the quality and the standards and what she has put in place or has overseen as far as that is concerned. But the reality is that, and the final thing is, we know as a, and it's a global reform conversation around universal health coverage. If you're to contextualize it in Kenya, we are seeing the conversation of SHA. So the question again I throw to us is, are we seeing the benefits or the entitlements of mothers and children standing out in the packages, whether it is the primary health care fund or the social health insurance fund or the emergency and critical illness fund? The reality is that it's very lean. And so we appreciate that it's a journey, but it is a priority that must then stand as a priority.
My plain answer. we have not ring-fenced money for maternal newborn health. And unless we get to that point, we're really wading in the waters. But there is hope. There is hope in this sense. We're building a momentum for bundling of care. So you have the basic obstetric unit around, we have comprehensive, and now we're even having critical care. That begins to tell me people recognize that there is complications that happen that should be avoided. That's one. Number two, I really want all of us in this room to change the narrative. What's the narrative I want changed? We've talked so much about disability-adjusted life years and mortality. That, to me, is end stream. What are we doing upstream? I worked with him in my younger life in a rural village. Don't ask how many years ago. But the main thing was primary health care, prevention, health promotion. Yes, high-income countries have recognized, and they're already moving in that direction. Why should we keep on waiting for disease states as opposed to mercy, you spending more time giving health literacy upstream for better outcomes? The incremental thing you guys talk about as finance people. The third thing is political goodwill. Wherever you are, we have to recognize the value of politicians in the conversation. And if there's no goodwill, forget it. It doesn't matter how glossy a hospital you put up. Look at the Kenyan situation with Nairobi Hospital, a little bit of politics, but that's the business of the day. The fourth thing, I long for the day where communities will wake up and stand up and say, I demand this kind of service. We're still very sublime. And I want to come and see facility X, which Anita is running, and see that she's accountable with the services she's providing. I think that's the narratives we need to start bringing on board if we're going to change maternal newborn health. Without that, we're still talking the same rhetoric. The fifth, and I want to give it with an example, bear with me.
That's okay, go ahead.
Every 2 minutes, a woman is dying. Every 16 seconds, a newborn is dying. Every day in the Masai Manyatas, a woman is cooking food using the 3-stone system, fossil fuel. Inhaling those fumes, she's pregnant with a third born. She's having a respiratory issue, if not tuberculosis, with the risk of it being spread to the unborn newborn. She has to go 70 kilometers to the nearest health facility. This isn't abstract. This is in Kajiado, an Asal region. Climate has come to torment women. I can't grow any food. And even where I can grow it, we're now over-flooded. Do I have food to feed myself, my family, let alone my pregnancy? As if that's not enough. I'm in a patriarchal system. I must start by feeding my man, feed my children, feed myself last. This is a typical woman's story in the village. Yeah. You told me to go to the village.
Yes, please.
Where is the interoperability of multi-sector in this conversation? The pooled financing I expect to see from multi-sector. So we keep talking to ourselves. How many here in agriculture? How many here are educationists? How many of us are in health? Hello, Anita.
Hello.
Next year we need a multi-sector so that this conversation becomes real with the development agenda. We have compartmentalized women as reproductive commodities. Oof. Let's take her holistically. Holistically. And with the roles she's supposed to do, right from the household to the economies of nations. That's what I see. Our narrative has to change.
I know you're itching to respond. Just go ahead. I've been seeing you. I've been seeing you, Bonnie. Go ahead.
And I just want to pick up from where she has left, because we have to begin seeing the value of maternal health from its reality. Because if we can be able to strengthen the provision of maternal health, we can be able to create trust for any other service within the health system. And that's why we have to to think about our policy making journey should be made with a person in mind. It must be made with a person in mind. We have to keep asking ourselves, how would this be for that woman in the ASAL area? How would that be for a woman living in the urban settlement? What do we need to change? What do we need to tweak? But we also have opportunities that we can be able to take.
Yeah.
And if you look at different countries, there are lessons that we can be able to pick. And allow me to pick just a few. One, here in Kenya, we moved from a place where we used to commit way less than $1. It's 10 shillings. 10 shillings is what? 0.01 of a dollar?
Yeah, it's about it's about 10 cents, right?
About
it's about 10
cents,
US cents, yes.
So imagine previously, there's a time as a government policy, we had said that delivery in a dispensary and a health center is 10 cents or 20 cents. And it was national policy. Right?
Yeah.
So what does that act then help us to do in the future now? Like, what does that help us to build up on? One is to recognize that it costs money to be able to deliver good maternal health services. That means that we have to commit resources.
Yeah.
And let's look at the journey that then the country took. You know, over the years, we went to Linda Mama. A recognition that, hey, we're telling people that this is free maternal service, but we are basically saying that we are going to commit resources to get it done. Yeah. So now, the realities that we must be able to observe is when we have such good lessons, then we should be able to build up on them and not forget them. The second thing that provides us an opportunity is to look at primary health care as an entry point for all the basic services that we can, including maternal and child health. Because if you look at all our different countries, there are more primary health care centers than we have tertiary and specialized hospitals. And that means that if we are going to have any good service, it has to be given to the lowest level.
Yeah.
Now, number three is to think about how that can be integrated with community health care work and ensure that every household gets connected to this broader system. The last thing, when we think about opportunities that we can be able to follow, is to allow ourselves to learn from other countries. So that if there are things they have done wrong, we don't repeat.
Yeah.
If there are things they have done good, we can be able to adapt. Because that is what policy should be agile enough that I can be able to learn from another country, and whether it's a good practice or a bad practice, but I should be able to avoid the bad practices that I have had over time discussed as points of evidence, so that I don't then have to carry the same burden of disease as I would have.
Great, thank you. And before any one of you jumps in, is there anybody with a question or a comment up to where we are at now? Anyone willing to? There is a hand there, Indrani. There is a hand on this side. Please, you can choose one of them to answer the question. Be as blunt as you want, or you can open it up for. Yes. All right. Go ahead. Please tell us your name and go shoot your question.
Yeah. Thank you. My name is Kenneth Ogendo, and I'm really inspired by the conversation by Professor Kihara, who apparently is a great champion and one of my mentors. And I would like to pick the conversation from where you left it for people to discuss.
Okay.
And I like that you are very candid. And I want to use Kenya as an example. I want to agree with you that we need to socialize the financing in sub-Saharan Africa. In Kenya, we have moved from the National Hospital Insurance Fund to Social Health Authority. And I would like to laud the government for that move, the attempt to socialize it. But again, what is our view towards financing? The Ministry of Education in this country, we are investing 700 billion. Whereas the Ministry of Health, we got 141 billion, national government. And if you look at the monies going to the counties, when if you add them up all together, you get to around 260 billion. So the question is, ladies and gentlemen, should you be healthy before you go to school, or should you be going to school when you're not healthy? So going back to the social determinants of health, how is the new global health reform agenda responding to the social determinants of health? You've asked us to put the mother and child at the center of it all.
Yeah.
But I find it that there are no known structures on how to bring the mother and the child into the conversation. So I work for Loala Community Alliance, and one thing I've seen working, which I would like to hear our thoughts, bringing the community health committees to keep the health system accountable would be something important. But you find our health system is not willing, or the players are not willing to fund such formations because people find them very abstract. And you know, if PHC really covers community health is a foundation. For the longest time, MNH has been brick and mortar. Right now, go to our counties, go to the field. You will find we have so many buildings, but we do not have the people working. So the thing is, should we reorient ourselves and focus on the software, invest in behavior change, empower these women through such structures? So I love the conversation, and I was just inspired, and yeah, back to you.
Lovely. Thank you so much. Prof, you will take that. And Mike, you also have to jump in because he talked about financing. A second question before we move? Or we let that sink because it is so heavy? All right.
Well, I know my mentee very well. We work together somewhere. We're Okoing Mama and Watoto with him. That's saving mothers and children. I want to take this differently and really look, because you're looking at the Kenyan context, the devolved health system. And I think for every nation that's sitting here, the first thing is you've got to do your own situation analysis. Where are we with my mothers, my newborn, my children, my adolescent, and their health? I agree with you. You cannot generate wealth without health. Do your situation analysis. It begins to give you localized context, very localized. Where you are, the burden of HIV, the burden of malaria, the intrauterine fetal growth restriction, very high. Where I am, and the Nyeri population there, we have substance abuse as our problem. We're not even getting pregnant from the men. Yeah? So get the context. Then it'll inform your priority. Now, we're lucky we have a layer called the County Integrated Development Planning. Again, how many of us sit to look at maternal newborn health there? We're talking a development agenda that is localized. And even move further, the annual working planning that you do for that particular state or province or county. Again, I see crevices. We're just not focusing because we are not valuing the role women and babies can bring to the table. The baby may not be immediate, but that's the citizenry for tomorrow. Surprise, mama. Then you talked policy, and I really liked that. But how gender transformative are the policies we produce? Again, another crevice. Budgets must then follow those CIDPs and annual work plans. But who's at the table? That's my problem. Who is at the table? Don't look at Anne. I can't be everywhere. I may be at national. I'm not at county. You're at county. But how oftenly do you even articulate your issues based on your context and priorities? And the fourth is that community that is struggling with the shisha. I call it shisha. Don't Yeah. But Shita, if I'm not getting the services I deserve, yet I have paid for this service, why aren't we raising our voices in agency? That's the problem I have. And really, at the end of the day, you need data. And data, unfortunately, in a lot of African nations is not real time. So we're doing retrospective analysis. I think the only thing that is currently real for everybody is MPDSR, because we've gotten that awakening. Bingo. We don't want anybody dying. We don't want any woman. We don't want any child. And we know what's causing the death. That's the only real time we seem to be doing within 24 hours. But honestly, are you trying to tell me in this day and age of 21st century, we can't get real time? If I can be on social media, you told me your name was? Kevin. David. If David puts a post right now on this session, it'll go viral. But why is it? It takes so long to get data in real time for decision making in Africa.
All right.
I have a big problem there.
I think the two of you need to have a meeting after this and continue this conversation. Mike, financing, Prof has mentioned budget. I'm sorry, it's all coming down to you. I can see you holding your hand.
No, it's interesting conversation. I will start with the conversation around socialization of maternal and newborn and child health, and the financing conversation. But as I start with that, I think it's important that we understand context. Yeah. What has worked in Germany as social health insurance will not necessarily work in Kenya in the name of social health insurance. We must appreciate the differences within our contexts. Number one, what is our GDP in terms of our economy? Germany, really, social health in itself is modeled around the Otto von Bismarck system, the Bismarckian system from Germany. From the 1880s, they've had it. But think about their GDP versus ours. Their GDP is about 25 times ours. Number two, look at their economy in terms of employment. Compare that with our employment levels. Look at our unemployment levels as a country versus theirs. Remember, social health insurance, which is largely contributory, you pay to access, is really hinged on employment or checkoffs, payroll deductions. The question is, in a country like ours where you have 85% in the informal sector, do you have a structure to net the informal sector? Last week, the reality is that I think even the health committee was decrying the risk we are facing as a country in terms of sustainability. So context matters. Yeah? When you have 85% of your labor force in the informal sector, then social health contributions are not sustainable. You end up burdening a small fraction. So the point you're passing across is we must appreciate our context, even as we're designing reforms. What has worked in Ghana may not necessarily work in our context. We must understand our context. That's number one. Number two is on the conversation of education and health. And I agree with you, they are priorities. But I wouldn't take it in a binary sense that we start with education and then health. The reality is that all this, given our context, are a challenge. We must not have the entire basket of free primary, secondary, tertiary education, free primary healthcare, free tertiary and secondary. We must live within our means. But all these things can actually happen simultaneously. The question is, have we prioritized them? What is our priority? Then even as we think around integration, integration is a good word. Sometimes the problem is you integrate and then you hide things and then you don't see them. So even as we talk about integration within primary healthcare, the question is, how do we ensure we still keep visible these things that we think are priority. Maternal and child health are a priority. And one of the things, like if you're looking at Kenya, for instance, we notice a decline in some of those core indicators since 2024. So the question is, even as we talk integration, are we keeping systems that will allow us to have visibility of these priority things? And the final thing around integration, even as we think around financing, there's a conversation of ring fencing. Controversial, because one of the key things you will end up doing sometimes as you think ring fencing is that you introduce silos within the budget. And one of the things you're running away from is silos. So that then, and the other question people will ask often is, so if we verticalize or ring fence for maternal and child health, will we ring fence for all these other things that we think are priority? Then as you do that, then it becomes administratively inefficient. So the question is, how do we prioritize what is core? And primary healthcare in itself is critical. Yeah. So that then as you finance that and you have visibility of what is priority for you, then your resources should follow that and not just ring fencing in itself is not the answer. Mm-hmm. It is an approach, but what more can be done beyond ring fencing? Mm-hmm. Thank you.
Mm-hmm. And I think just picking up from the comments, it is very good for us to be proud to have local solutions.
Yeah.
I sometimes feel like we tend to feel like local solutions are not good enough. We should get local solutions. And I wanted to put that into context. I went to one of the counties in Kenya that is in the arid and semi-arid areas, and I found this nurse who kept asking how can he help to change maternal deaths in their community. And he realized because of the community that he was living in, there were challenges with delivery inside a brick and mortar unit.
Facility.
And this is in Samburu. Samburu is some distance from here. And so what he did, and this is, we're talking about local solutions. So this nurse then decided to create a manyatta inside the local health facility. And then
a manyatta is basically a traditional house. For those who are not familiar with the Kenyan setting and lingo. Yes. It's a traditional house that's ideally you'd make it out of mud and then it's dome shaped. Others would use grass and cow dung, but it's traditionally where some communities like the Samburu, the Maasai would prefer to stay and live. It's cool, actually. It's very, it's very nice. It's cool in there. It's very friendly. The environment there is very friendly. So it's their most preferred mode, their most preferred place to stay because they live in really, really hot places as well.
Yeah. So now the manyatta became the symbol of innovation, local innovation, that was then going to assist, to support mothers to make that decision of delivering in a health facility. And he assured them that he was going to be available. That was then followed up by a lot of mobilization by community healthcare workers, who then were able to bring the mothers to deliver in the facility. And that again was linked with the financing mechanism of the day that then allowed the facility to get some money from the work that. So local solutions, very, very important. The other thing that we have to be able to understand is we must look beyond the numbers. Yeah. You know, we like telling people we have delivered 10,000, 10 million mothers. But in between there, we hide many things in the numbers. And I think we need to be
like what?
Inquisitive.
Like what?
We hide maternal death, we hide the perinatal deaths that are significant. Mm-hmm. And we need to be able to have a way of bringing these numbers to reality and then using those numbers to champion for accountability. The third thing is to be able to champion for multi-sectoral collaboration. And multi-sector collaboration has been with us since 1978. But it's a very simple thing. It's just to say that I need help from another person to get the work done. And all that, very simple, but we can be able to apply it across different sectors. Now, when we say that, it is important for us to sit down as countries and ask ourselves, why are we losing mothers? What can we do about it? Because many times, mothers die and we continue with life.
But we know why we are losing mothers and we know why we are losing babies, right, Bonnie?
Yes,
We do.
but sometimes we hide that in the numbers.
Yeah.
So we have to use the numbers to take action.
All right.
So,
Okay.
for me, without data, you're dead. I don't see data as a tool. I actually see it as pertinent infrastructure in a health system. Why do I say this? He's talking numbers. It's beyond numbers. You've got trend analysis. You've got benchmarking with the next area. You've got hot spotting. Where are those critical points where I have pain points? You have prediction. Now I'm going even to the other realm of innovative AI, but good AI, not bad AI. So good AI will even give me prediction right up to that index patient. So my prediction and my precision care, it's data, data, data. And I'll tell you, Mercy, I don't care how much these guys have in their basket. Without marrying finance with what's happening in outcomes and my maternal experiential with the health system, we're not going to achieve much. And this is an opportunity we have. The fact that we're now moving to digital technology and digital platforms, the Act is here, the Primary Healthcare Act came out, the Financing Act came out, they all came out at one time, one touch. I could actually see where the president was going with this, and it really should happen in all African nations. The issue of looking at data retrospectively and not even getting to know the lived experience of women. Yeah? Even something as simple as, was it respectful care or not? She will go and tell 10 of her friends, hey, that facility where you find Anne, steer clear. They pinch, they do whatever. You know, women talk. Women talk. But when you do a good turn, they can talk twice over.
Yeah.
So how much of capture of this are we getting? And I'm at a point where I feel for every facility, there must be some qualitative research being done around the facility to find out how are you treating those women and babies.
Okay. Thank
so
you.
that it matters.
Thank you very much. Anyone from the audience? Question? Reflection? There's a hand there right next to you, Indrani. Very briefly, we have just maybe 15 minutes. Wrap this up. Go
It's
ahead.
a very different type of question.
Okay.
I come from a part of the world where money is siphoned off by the leaders. So now we're talking about all this financing and thing, and I'm sure more money is siphoned off than goes to health. That's one. And these leaders never use this health system that we're trying to build up. They use a private system. So how do then? I mean, I can talk about improving all these things, but how do we get that? Get the actual basic injustice.
Accountability.
Yeah.
Accountability. Yes. Let me go to you, Bonnie. Very, very briefly.
I think we have to be able to help our people to raise accountability voices. I think that citizens' role does not end in elections.
Yep.
It continues in putting leaders to account. And there is a semblance of movement towards this, but it's not yet fully formed. How many of our presidents are elected on account of their priority to health? And then how can we take that conversation further and say, okay, fine, you have committed to support health. What in health are you going to support? And then we have those kind of conversations where that if we get to hear of the next demonstration, it's not about this leader, that leader. It's because they did not do certain things in the health sector. You see, it has to get to that point where citizens begin to account. And if you look at the trends in some of the high-income countries, a bit of that can be picked in some of the countries. I remember some time ago, I think about three or 4 years ago, there is a government in Finland that resigned on account of them not fulfilling their promise on health. I long for the day a country will resign in Africa because they have not met the promise that they have made to citizenry. I long for the day that I'll hear a minister has resigned because mothers are dead. And we have to get to that point. Why I keep saying about we have to keep looking at beyond the numbers is because sometimes our political people want to show us the glossiness of the good things that have been done, and they hide the things that are in there. So for example, in Kenya, we now have a reform on the Digital Health Authority. Yeah. Very good. And lots of data. But the issue is, when shall we start using this data to make the decision? That's a real issue. The data is there. It's real time. When shall we start saying that the decisions that we are doing today are because of the data that we saw yesterday, or the data that we saw this morning? So we have to get to that point where data promotes action. And in AMREF, we have come up with what we call a primary healthcare accelerator bundle. And one of the key items in that is data must trigger action. Yeah. And that must be broken down in the way it should be to communities so that they are able to demand for that same kind of accountability with their leadership.
I want to add, what's the role of professional bodies? I actually feel we've taken a back burner and should be central to the table. You are engaging with capacity building. You're engaging in policy making. You're engaging in guidelines. Why aren't you engaging in accountability? The media, my friend here, how much of co-relationship do we have? They make noise independent of me. She may not be the technical expert. No, I'm being honest.
Okay.
You may be the technical expert
Real
with
talk.
communication.
I said,
talk,
let's
yeah?
be honest, but I didn't say.
No, with you I can say it. Or let me pick on Luala up there. My community, CBO. When do we have conversations as a tripartite? The technical expert, the duty bearer and the politician, my media, in understanding and being the voice for this voiceless 85-year-old with a 19-year-old daughter who's gotten pregnant. So I think we have that potential to come together. Because again, let's be honest, if I confront the government of the day, I'll be victimized as an individual. But if we're talking as a collective and putting them to book and being at the table, that makes all the difference. So for that accountability to really stand out, I think we've got to really work as one.
No, thank you. Thank you very much. I think you said you come from a part of the world. I think it's also the same. You come from this side as well.
Where do you come from? She can't say where she...
She'll be talking about us. So let her not mention the side.
Do you want to say she comes from Kenya?
Well, yes, this side of the world.
Oh, this side of the world, okay.
Yes, this side of the
world, fine.
Where respect for public resources is a suggestion and not a reality, unfortunately so. And I'm happy that the conversation on accountability has come up because Kenya is a good example that the citizens can actually rise to the occasion and stamp the authority as far as accountability is concerned. When you look at the Gen Z movement, and even now the politicians are shuddering simply because the Gen Z are very unpredictable, unstructured, and disrespectful, as they call them. But the reality is that we need to get to the point where the citizens are informed and rise to the occasion to claim what is rightfully theirs, because these public resources are theirs. That's one. The other reality is that if you're thinking about a socialized system, as our friend from Luala was suggesting, then we must also appreciate the thing around public trust. There is no way I will want to contribute my taxes or my wage towards a public pot that I know is being siphoned on a daily basis. And it's not a wonder. Let's use Kenya as an example. We have the Social Health Authority and the registrations, only 17% are actually actively contributing. That tells you if you want to have 100% contribution, 17% are the only ones who are actively engaged. That gives you a score as far as public trust is concerned. So the key thing here is you may have a citizen that will go out into the streets, or you'll have those who will protest silently and just give you the 17% because that is a score of the public trust that they apportion to you. But the point here is accountability must start with an empowerment of the citizens to rise to the occasion and claim what is rightfully theirs. Thanks.
And be disrespectful.
Oh, yes.
He said we should be disrespectful, in quotes.
I want dialogue. And we have opportunities for dialogue, because when we say be disrespectful, it gives a different connotation. But where we have public forums, which do exist in almost all our nations, I think that really gives you a nidus for accountability. Where you have technical working groups in Ministry of Health, again, that's another forum for accountability. Where you have the political dispensation, what is your manifesto telling us? And what's our conversation around that? I know a lot of African nations between June and next year, they're all going into elections. Where is your voice? And particularly even as the professionals, where is your voice? We wait for the bad things to happen. It's reported by my friend here. Yeah? But the good things, even the good things. So I think we need to even start painting good, bad, and ugly, so that we also can give ourselves accolades. Where we've done good, mention it. Where we've done bad, or we're at our worst, report it. But give it with a solution pathway.
And I think it's good to add something there, that within these changing global health reforms, accountability cannot be diluted.
Yeah.
We should even be more accountable with our resources than we have been with resources from other countries. And one time I interacted with members of parliament from Germany, and I got to see the kind of questions they ask about the use of their taxes.
Yeah.
And we have to be able to learn some of these things and say citizens must question where their investment is being put, and particularly on services like maternal health and primary health care. The second thing is it's good to remember that accountability comes from, rather the demand for accountability comes from an informed citizen.
Yeah.
Because when a citizen is not informed, they feel sorry that they did not get good service.
Yeah.
However, an informed citizen does not feel sorry for not getting, it gets agitated if the service is not what they expected. Not the difference.
Yes.
The first one is sorry that they did not get what they
deserve. Yeah.
The other one gets annoyed, but that they did not get with the quality they were
They wanted,
expecting.
yes.
And so there must be, conversations to help citizens to appreciate their bigger role in raising accountability.
Allow me to, we need to wrap this up. So allow me to just, because I need to go to a poll that we did. Good people. So we asked people online about this exact question we're talking about today. As global health shifts towards integrated country-led systems, as we go to, all this, the reform agenda, are we looking at this as a threat or as an opportunity for maternal and newborn health? You have talked about so many things, from accountability to, financing to sovereignty, but all that while keeping in mind that mothers and babies are at the center of it. So these were the results. About 82% said it's an opportunity. 7% said it's a threat, and 11% said it's both. Are we being optimistic, or are we underestimating the risk for mothers and babies in this whole agenda?
So I think the rating of opportunity gives us a lot of hope. However, we must make that hope a reality. Sometimes when I look at certain data sets, I want to ensure that we can be able to internalize it at the local level. If you imagine that some of our countries here in Africa lose as many as 500 mothers out of every 100,000 live births, and there are countries in the world that lose only 5, 10.
Yeah.
You get the point?
Yeah.
We are not children of a lesser God. And we owe it to our citizen to make good service a reality, not a promise.
Opportunity or threat or both?
It's
for
an opportunity.
MNH.
It's an opportunity that
Opportunity.
we must work hard to make a reality.
Mike, are we being over optimistic? Is this agenda, as it is now, with all our problems, with everything we've spoken about here, is this an opportunity or a threat or both for mothers and newborns?
So looking at the data that we have, 82%, that tells us that the majority see this as an opportunity. And I think that's really just a good representation of, because as citizens, we know the potential that we have that has festered untapped. And I think that's why most of the people ranked it as an opportunity, because we know perhaps this is the opportunity for our countries to step up and take on this responsibility that has been theirs, yet they have delegated it elsewhere to others. So I think in itself, it is an opportunity. There are risks. We are not burying our heads in the sand. So the question is, how do we mitigate this risk in the short term? Because we know structuring systems to fully adapt and take on the roles that were taken over that were previously handled by donors may not be an immediate thing. So what do we do in the intervening period to ensure that those who are vulnerable are still protected, even as we work around the long-term reforms and fully taking over as government?
Prof, opportunity or reform for mothers and newborns, this global health agenda?
The global health agenda has certainly disrupted the world. The world, not just Kenya or Africa. But I see it as a golden opportunity to evolve maternal newborn health. Why do I say this? Less financing, let's learn to do more with less. That's one. The more with less, we'll put the devil in the detail. Health system, dependency syndrome, from equipping to name it, you just need to take those pillars. We need to shake ourselves towards having self-reliance. Where you don't have the health workforce, what do we have now in place? Technology is here. So where I expected to have 6, 7 midwives attending to my 30 patients, What can I do technologically to relieve her to deal with the critical care? Just examples, yeah? So I see this as we need disruptive thinking. We can't go as business as usual. We can't, and we shouldn't. And number two is to actually drive context, priority, data-driven, patient-centered care. I see this as the golden time.
Thank you very much. One thing, it's 2035.
2035.
Yes, it's
Yeah.
2035.
Okay.
Maternal and newborn health has not just survived these reforms, but it is thriving. What did we get right between now and then in 30 seconds? It's 2035. MNH has not just survived these reforms, it's thriving. What did we get right?
You transformed your health system. Simple.
Mike, 2035, what did we get right?
You invested. You became more efficient with the resources that you have, and you used evidence to improve the quality within your constraints.
Bonnie,
You put your patient at the center, and you combine the resources to address the underlying problems, so
great.
that you can be able to offer better services.
Thank you very much. Good people. That's real talk for you. And we could do this for the next 1 hour, but I have to end it here. Thank you so much for staying put. I will give them 5 more minutes. I know I didn't come back to you with, any questions or anything, but I will ask them to stay here for 5 minutes, stand here. If you need them to talk about anything, if you need them to address it, please come and say hello and talk to them. But thank you so much for being a wonderful audience, and see you next time when we start another Real Talk. We are going to be as candid as ever. Thank you very much and enjoy your evening.